lecture, Dr. Mayur Kulkarni sir. He is a MD DNB in radiology. He is a consultant radiologist and fetal imaging expert and director at the Sri Diagnostic Pune. He is the author of 3 best-selling books: One Touch Radiology, Conceptual Review of Radiology, then Radiodiagnosis and Imaging by CBS Publisher. He is a faculty of radiology on Marrow app. He is a renowned radiology faculty for NEET PG, FMG examinations for the last 14 years, and he is a pioneer of RAD Imagine Animation Interactive Graphics Animation for radiology teaching, and has also presented and published multiple case reports, articles in renowned international conferences and index journal. Okay. So with that warm welcome, I hand over this mic to the Kulkarni sir.
Good morning, everyone. Respected dignitaries, all faculties, and my dear friends. If there is one word that can summarize the ethos or the environment that we are right now in this age of AI, it is imagination. Albert Einstein said that imagination is more powerful than knowledge. He said knowledge can be limited, imagination is limitless. Imagination is like the language of the soul. Now, in this day and age of AI, if you can imagine something, AI will really make it happen for you. But before, we are going to do a lot of imagination today. Well, it might seem like imagination to you, but these are actually all clinically proven models. Many of them are USFDA approved models which are being used in day-to-day medical practice that we are going to go through and see get to know the fascinating world of AI in medicine. Before we get there, now a couple of years back, I lost a very dear friend of mine. She was on a low dose of steroids for an autoimmune condition, got admitted to a hospital for a routine minor surgical procedure, developed a fever spike 2 days later, had high counts, did not feel well, went into hypotension, multi-organ failure, and it was sepsis. Within 2 to 3 days of admission, we lost a bright young mind who had a very bright future in radiology. That got me thinking as to whether we could have done something that could have saved that precious life. The diagnosis in her case was sepsis. And when I did a little bit of deep dive into this particular entity and what impact it has on lives, the results were very shocking. India reported about 11 million cases of sepsis in the hospitals last year, with about 3 million deaths. That's a very high mortality, right? 26% of the global sepsis burden comes from India. ICU sepsis in our hospitals have a mortality of about 26 to 40%. Can we do something, to get over this problem? Can we mitigate it? Can we minimize the impact of this particular problem? When I did extensive search, I was surprised because there are a lot of models available today, used in practice, right, which can help us detect sepsis hours in advance than what is routinely done in our day-to-day practice, and thus lives can be saved, because time lost with this diagnosis is life lost. We'll get to that. We'll get to these models and how they work. Well, welcome to Dr. 2.0, Reimagining Medicine in an AI-driven world. Let me at the outset thank the organizers of MEDIACE, the faculties, the team that has given me this platform. I'm honored to be here at this prestigious institute. I want to specifically thank Dr. Sanjay Nathu sir, Bahar Kulkarni sir, Prashant Naik sir. They have taught me lessons much beyond clinical practice. They have taught me lessons for life. Dr. Rohan Khandelwal sir, my friend from Marrow, who was here a couple of days back, interactions with him has taught me a lot, and my family remains my strong pillar. And of course, thanks to ChatGPT, because full disclosure, I have used a lot of ChatGPT in preparing my talk today. And it has helped me a lot. It has helped me make a better presentation in front of you. Just because ChatGPT is so readily available with us, I want this talk not to be a didactic one where it is a one-way communication. I want to interact with you a little bit. How many of you in this auditorium use ChatGPT on a day-to-day basis? Can I have a show of hands? Yes, many hands going up. So have you used ChatGPT? The answer is yes. How many of you have really used it for legitimate academic purposes? Not for writing your thesis, not for writing your answers, not to create your journals, but yes, I can still, see many hands going up there, and that's really good. The perception that we have about AI is somewhat threatening or skeptical when we think of these tools here to replace ourselves. But that is not the right perception to have, and we'll get there in some time. So for those of you, I am an MCQ guy, let me tell you. I go and teach for classes and I help students master the art of solving MCQs. So I thought, why not use it a little bit here. For those of you who put your hands up that you use ChatGPT, can you tell me what is GPT in ChatGPT? Anyone? Yes, so let me give you some options. Generalized commutative table, generalized function transformer, generative performance transducer, generative pre-trained transformer. Anyone? What is ChatGPT? What is GPT? Well, GPT in chat is basically, it's a chatbot. You can chat with it. And this GPT is basically generative pre-trained transformer. Generative is because it can generate responses. It is based on large language models. So it can actually generate a response, it can generate images, it can generate content, right? It is pre-trained on not millions, but billions and billions of data points, websites, articles, publications and all these things. And transformer is basically the architecture that the model is based on. It can use language in a sequential manner to generate responses. So that is what is ChatGPT for you. What we are going to do today is, first 10 minutes, we are going to just get acquainted with the basics of AI. Because we have been using all these tools, we need to understand what lies underneath them and how it actually works. Once we are done with that, I know each one of you here wants me to answer a particular question, and I saw the debate round which was going on here, and it brought back memories because I was many a times a debate finalist in my undergraduate days. And those skills have helped me, because nowadays I am also fighting a debate continuously. The debate is about whether or not AI will replace people like me, right, in the near future. And that is something that we will dwell with, in today's discussion. Then, very important, as I said, imagination is the key word here. We are going to, sort of imagine what applications AI could have, and we are going to discuss these use cases and their practicality. We are going to imagine, we are going to get creative here. At the end, to summarize, we are going to answer some million-dollar questions with respects of using AI in clinical practice. So tell me, how old is this technology of AI, right? I said I'm an MCQ guy. I'm going to trouble with you some MCQs today. Can you tell me? So 1970s, 80s was when computers actually began, to evolve. It was in the 2000s and 1990s that Microsoft, Google, and all these companies came up. It was just about late 2015 that ChatGPT, late 2018 rather, ChatGPT actually came into being. Since when do you think is the entity of AI, the origin can be traced back to? Any wild guess? You will be shocked to know that AI actually originated in the 1950s. It's as old as that. All we know about today is this ChatGPT, which was the version 1.0 was launched in. The most recent one was, that is the ChatGPT 3.5 was launched in 2022. What we are using today is ChatGPT 4.0, that is Omni one version, right? But if you trace it back, it was in the year 1950 that Alan Turing actually established the Turing test to determine whether a particular system can be called as an intelligent system. That test stands valid even today. It was actually in the year 1956 that artificial intelligence was actually coined by John McCarthy. With the evolution of computers, machine learning, deep learning, computer vision, robotics in the 1990s and 2000s, it started gaining quite a bit of a momentum. With the 2000s, with the likes of Google, Amazon, Netflix, Facebook, it gained some pace. Generative AI actually started in 2010s, and this is where we are starting today. The graph is going to go up exponentially as to how to use them. So what is artificial intelligence? It is basically a branch of computer science which is focused on building systems to perform tasks that requires human intelligence. So what a human intelligence can do, we are sort of using a computer system to build these computer science basis to build these particular systems. So is ChatGPT an example? Yes, of course, it is the prototype example. It can generate responses, it can write poems, articles, it can write essays for you, it can do a literature search for you. So that is what artificial intelligence is. Two types of artificial intelligence called as strong AI and weak AI. Weak there, I have written in italic, don't underestimate it because the name, though it is written as weak, it is potent, right, from what it can do. So strong AI is called as general AI or artificial general intelligence. It is that human level of intelligence, right? Everything that a human can do, if a machine or a model can do, it is called as a strong AI model. It is a very ambitious one. Even today, believe me, this particular one strong AI is still hypothetical and theoretical. We have not been able to achieve that. And sometimes, I feel that this human intelligence that we are gifted with, it is sometimes underrated, right? Because we feel, we assume the tasks that we do on a day-to-day basis so easily, but when you actually ask a machine to do it, it's very difficult. So we have not been able to achieve this right now. Whatever we are using till date, everything falls under the category of, most of it, right, falls into the category of weak AI. This has been designed and trained for a specific task. It does not have any self-awareness, no consciousness. Uber, Siri, Alexa, all the diagnostic tools used in practice, this is basically weak AI. There's something in between a weak AI and a strong AI, and that is ChatGPT. Why is that so? And that is because of the deep learning algorithms that it has. What is deep learning? What is machine learning? We are going to quickly see that in the next few minutes. Now that we have done with the basic structure of AI, that is the anatomy of AI, let us quickly look at what is the physiology of artificial intelligence. So artificial intelligence models basically work on three important steps. One is that they need primary data, that is what they are focused on. Two, they need reasoning, they process that data and they develop their own reasoning and then they act upon it. So let us take an example of ChatGPT and see how it works before we take it into medical practice. So ChatGPT has been trained on a lot of billions of data points. Where do these data points come from? They come from websites, books, articles, Wikipedia, license consent, all the open source material. That is where ChatGPT is trained upon. Once that is done, ChatGPT uses various tools such as large language models. That is how it is able to understand what you're trying to say in sentences. It uses machine learning, deep learning, based inference, computer vision, pattern recognition. These are all the. Now, to make it, this can be a slightly difficult jargon to quickly and easily understand what does this mean. Let us quickly look at the difference between a coded software versus an AI. I'll give you an example. Suppose you're writing a software and you're trying to code, you're trying to enable that software to drive a car. So what do? You write a code asking the software to press the accelerator. Once the RPM goes up, press the clutch, change the gear. So you write a code for each and every step in the process. That is a coded software, right? Now what is machine learning? You don't write a code. You give a driver's driving manual. See a driving manual to that particular machine. The machine reads it on its own and learns how to drive. That is called as machine learning. And what is deep learning? See how fascinating it is. You don't write a code. You don't give it a manual. The machine simply observes a driver driving a car, and by observing the steps that the driver is taking, the machine learns it on its own. Now can you see the limitless potential that it has? Right? This is what is deep learning. So there's now no code written there, no manual given there. Just by observing, the machine is learning on its own. That is what is called as deep learning. Now, based on all these things, your ChatGPT can write poems, essays, emails, summarizes text, writes code, does a SWOT analysis and all these things. Now let us look at all the artificial intelligence tools that can be used in medical practice. It has to follow the same critical steps. So we have to train it on data. What data should it be? It should be patient parameter data, chest X-ray, mammograms, drug profiles, skin lesions. There is a problem with this data. Medical data is very heterogeneous. A patient has not undergone an ECG on the same day of every year. 1 year he has undergone an ECG, the other year he has a chest X-ray, the other year he has undergone an ultrasound. The data is very scattered, the data is not homogeneous. There is a lot of variability in this data from person to person, and that is where the first challenge comes. Then you use all these analytics. There is computer vision. right, from which the models can look at chest x-rays, mammograms, can do interpretations, right? From all this parameter data, it can do a pattern recognition. So far it is good, right? It looks positive, it is going to help us. But when we think of AI as taking action over that particular data, this is where there could be a problem. So either khatra hai, because can we really rely on this system? What if there is an error? Just imagine this. There are so many accidents happening on the highway every other day. But when we think of an automatic, driverless car, our threshold is that there should not be even a single accident happening. So can we really entrust the lives of our patients in the hand of AI? It's a big challenge, and that is where the real challenge lies today in healthcare. So every other day we come across news, we'll say that AI will replace all doctors soon, and the other article says that it will never be replaced. We go with all these things, and what is the perception that we get about AI? So tell me, as a doctor, what is your first reaction when you hear the term artificial intelligence? Come on, be honest with me. Are you super excited? Are you angry at it? Are you skeptical? Are you threatened? Yeah? Anyone who feels a little bit skeptical or threatened with AI? Show of hands. Yes, I can see a few hands going up. Anyone here who is super excited about AI? Yes, again a show of hands. Believe me, this is one MCQ where I've really tricked you, because there is no one correct answer here, right? All of them could be correct. The point here is that, whether you love AI or whether you hate AI, you just cannot ignore AI in this point of time. What is the correct perception that we should have about AI? I'm just coming to that in a couple of minutes. Do we use AI in our day-to-day life? I'm not speaking about your medical practice, day-to-day practice, clinical practice. Do we use AI? Answer is definitely yes. We might not be aware of it, but if you use Google as a search engine, nowadays, if you go and search anything on Google, before you get the website links, there is an AI summary which comes at the top. Have you noticed it? Right? So Google has incorporated the AI algorithms almost since the last 2 decades or so. What is Google doing? It is acting as a tool to get you to your destination, to get you to these articles, links, websites that you want to go. I'm sure you must have used Uber or Ola. What is it doing? It is incorporating artificial intelligence to connect you to a nearby driver. The driver wants to go to a particular locality in the city. You also want to go to a particular locality in the city. What the model is doing is, it is basically coupling you up. It is automatically deciding the search prices depending upon what the demand and supply is. It is an excellent example of AI being used in day-to-day practice. Google Maps, long gone are the days where you used to stop by the roadside and ask someone about directions. Now it takes you to your destination very well, right? Siri, yes. So when you ask Siri to do something, it not only converts your text into its understanding, but also opens files, types messages for you, responds to your calls, and does all these things. Each one of them is an example of artificial intelligence that we are using so seamlessly in our day-to-day lives. So what are all these entities doing? All these entities are basically acting as tools to make our life better, isn't it? They all are making our life better. Now, as a medical professional, do we use some tools in our day-to-day practice? The answer is yes, right? The first tool that each one of us proudly carries around is a stethoscope. Is it a tool that makes our clinical practice better? Definitely yes. It is an irreplaceable part of our practice. Do we use a pulse oximeter? Do we use a sphygmomanometer? Do we use a Holter monitors? Yes. Each one of this is a tool that makes our life as a doctor easy. It gives us a lot of information, right? Now, let us take the example of a stethoscope. Before the stethoscope was actually invented, physicians would keep their ears on the chest of a patient or the back of the patient, and they used to directly listen to those breath sounds and the heart sounds. It was in the year 1816 that René Laennec first invented the stethoscope. And if you do a quick search, you'll find what was the reaction of the doctors who were established doctors at that time when the stethoscope was first introduced. The idea of stethoscope was met with a lot of skepticism. It was met with a lot of ridicule. Doctors thought, oh, this is a gimmick. They wanted that, human touch so that they could directly listen to the sound, right? But what happened over time is that it has been gradually accepted. adopted into practice. Now I'll tell you what will happen in today's age. Last year, in the year 2024, there was a AI-powered stethoscope which was launched. How does it work? Right, you auscultate, it picks up the heart sounds, it picks up the breath sounds, it is fed to an app, the model analyzes it and gives you a better and objective diagnosis. And you know what happened when this stethoscope was launched at a conference recently? It was met with the same skepticism, it was met with the same ridicule from the senior physicians, but you know what will happen in the next few years? It will also be gradually accepted into practice, right? So with this example, you know, I want to highlight the fact that these tools that we use that make our life so better, be it Uber, be it Google, right? That is the same role that AI plays into medical practice. It acts as tools to make our life better, not just ordinary tools, but augmenting tools. They are going to help us perform better for our patients or save a few more lives. So these are augmenting tools to make our life and practice better. If you look at AI in this manner, if this is the perception that we have about AI, you'll stop feeling threatened. You'll stop feeling skeptical. AI is not here to replace you, right? AI is here to, you know, empower you, to augment your practice, to make your practice a better one. This is the correct perception that we as doctors should have about AI. As I spoke about the word replacement, I have to address the elephant in the room. And the elephant in the room in this picture is me as a radiologist practicing here. And each one of you is, you know, wondering, will AI replace radiologists? So when you call a radiologist for an AI-based talk, you know, this is something that which I have to address. Now, there are a lot of articles which were published throughout many years saying that some said AI will definitely replace radiologists, the other said no, it just cannot replace one. But the most prominent I found was a quote from a very eminent Nobel laureate, Geoffrey Hinton. Look at the date, what he said on November 24, 2016, he said, I think if you work as a radiologist, you are like Wile E. Coyote in the cartoon, you're already over the edge of the cliff, but you haven't yet looked down. There is no ground underneath your feet. People should stop training radiologists now, he said. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. Look at the date when he said that. It was 2016. And what is the date today? It is 28th of June, 2025. 9 years after that date, after prediction for the 5 years that he had made, it has almost been 9 years. And I am still sitting here, or standing here in front of you, sitting in my department, reporting scans. With an ever-increasing workload that I'm facing, an ever-increasing demand for radiologists going around, has it replaced radiologists? Definitely not, right? So AI and radiologists have a kind of a love-hate relationship. So AI, in some ways, is better than a human radiologist in making image interpretation. I have to admit that. A large study has shown that as far as chest X-ray interpretation is concerned, radiologists have about a 4% error rate for interpreting chest X-rays, whereas AI models, FDA-approved AI models, have an error rate of less than 1%. So for the time's sake, in certain aspects, CT and MR and ultrasound radiologists are doing good, but for X-ray mammographies, AI models are really working well. At this point in time, there is a tough competition between them as to who would do better in these interpretations. But if we look at ethical issues, diagnostic dilemmas that come up, incidental findings, right, that come up when you see a patient for routine fitness checkup, pre-employment checkups, legal implications, and how to word a particular report, what implications it would have. In these scenarios, a human radiologist with a human intervention and touch is definitely doing better. Now, will radiologists fight back? So I have been asked this many times. What will you do when AI takes over your job? I said, I'm not afraid of AI taking over my job. Let me give you an example. Many years ago, when these angioplasty procedures were being done in their early stages and these intravascular stents were being placed, what was the reaction that cardiothoracic surgeons had? Right? They ridiculed it. They thought it was a gimmick. They thought that these particular stents will get clogged. They will create clots into the arteries and create more complications. They did not accept it initially, but if you look at history now, these stents have probably saved an equal number of lives as compared to the surgeries that have been done for bypass grafts. What was the reaction of general surgeons when the laparoscopic surgery technique was first introduced? They thought it would be impractical. They thought it could not be used for complicated surgeries for large tumors. Now is the time and age where every surgeon wants to learn the laparoscopic technique. Will there be a pushback from radiologists? Possible, right? That's human nature. But eventually radiologists will have to fall in line and adopt AI into their day-to-day practice. I said, what is the correct perception we should have about AI? It's not that they are going to replace you, but it is that they are going to act as an augmenting tool to make your practice better. If we keep that kind of a perception, that kind of an attitude, I don't think we have a conflict with AI. We can have a good and healthy relationship with it. So AI can be used to ease cognitive overload. I am doing a scan in my clinic from 9 a.m. to 9 p.m. It's an overload of information. I can get tired. I can use AI models to just screen these scans before I report them. That will help the load a little bit. Excessive workload, peripheral centers, lot of scans, lot of chest x-rays, 500 chest x-rays reported every day in big institutes. AI help there. ER triad. So if I have, say, 10 CT scans done, the AI model will look at those CT scans and tell me which one of these 10 needs to be reported first. Because there is a bleed in one, there is a big subarachnoid hemorrhage. That is how the work list can progress. So AI can help there. Emergency provisional reporting, say 3 a.m. in the middle of the night, a CT scan head has been done, there's no radiologist available. Can we generate a automated report? The answer is yes. So that is where AI can really play a good role. So hence you're cordially invited to the wedding of radiologists and AI. This is the most scanned, analyzed, pixel-perfect union in medical history. The date is when radiologist finally stopped ignoring the algorithm's prompts. That is when he decided to acknowledge the relationship and get better at it. Venue is Pax Palace, Radioville Sector 4 near Neural Network Nagar. Do you want to know what their story was? It all started with a misdiagnosis. So when the radiologist missed a diagnosis, then came the recommendation engine. Their signals aligned and now they are ready to merge, hopefully with no or minimal errors. So that is what is the wedding with a radiologist and an AI is going to be looking at. Thank you. Now is the segment where we start imagining. Believe me, though we are going to, it is going to seem like we are imagining things, right? Most of these models that we are going to see here are actually being used in clinical practice to increase the productivity. I had a small, stint with AI. To be honest, this is not true AI because we wrote a software back when I was a resident at Sassoon in the year 2012-13. We published an article about acute brain hemorrhage diagnosis system where we used to feed these images to software, and it used to use some primitive neural networks to learn so that it would analyze these bleeds, the EDH, the SDH bleeds, intraparenchymal bleeds, and it used to make a diagnosis based on its shape. But as is what happens with most of us in our routine practice, we work on something new, but then our exams, thesis, and routine work comes along and we don't look at it. I did not look at it after that. And now when I did a search, there are precise models which are available for the same particular purpose. So look at this. Patient comes with acute left-sided hemiplegia at a rural hospital. Vitals are stable, undergoes a non-contrast CT, and this is the finding in non-contrast CT. There is no radiologist available. It's 3:30 a.m. in the middle of the night. And what the technician then does is that he just uses an FDA-approved model. This is Viz AI, which is available commercially. It has a neuro suite, cardio suite, vascular suite. A diagnosis can be made. What is very important of using all these things is that what is the impact that it has on the patient's life? Because there is an acute ischemic infarct that we can see there. It is a right MCA territory acute infarct. The patient can be thrombolized. And it has shown, to reduce the door to needle time by about 30 to 40%, which means that the patient can be thrombolized earlier. The patient outcome can be improved. So this is a USFDA approved model which is being used. So a patient comes for a routine pre-employment checkup and a chest X-ray is being done. before it is reported by the radiologist, the the hospital has a protocol to run it through an AI system. And when they do run this X-ray in an AI system which is called as LUNIT, again an FDA-approved chest X-ray interpretation model, what they find on this supposedly normal-looking chest X-ray is that there is a nodule there. And that is a solitary pulmonary nodule, and SPN, most of them are benign, but could it be an early malignancy that we could have detected? Possible. So it will need further evaluation. That is how we can actually pick it up, right? So not just a nodule, pneumothorax, atelectasis, cardiomegaly, calcifications, effusions, pneumoperitoneum, most of the critical things, it is very well established to detect. Impact is SPN detection, early detection of malignancy, and we can screen and scan these patients better. Now, similar model for TB detection, this has been used for mass studies in India. This is cure.ai. So it can detect consolidations, right, within the lungs. It can be used in mass screening programs for tuberculosis. This is something which has also been used, quick detection. So 42-year-old came for breast examination and screening, a mammogram was done, seemingly looked all right. Again, as a protocol, they run it through a reporting software. This is iCAD Profound AI. It helps us detect these microcalcifications in a pleomorphic linear microcalcifications within the breast. The patient is then sent for further imaging or biopsy. So this is something which has improved the detection rate, faster reporting, higher productivity. Now, does it mean it is going to replace a breast radiologist? The answer is no. Now currently, if I look at one of my close friend works at a breast imaging unit in the city, a very prominent one, a very busy unit. They can do about 25 patients every day for mammography and sonography. That she works there for 6 hours. They can do about 25 patients there. When she uses this particular model, her efficiency increases, and then she can do about 40 cases a day. This is a good impact. So this is how AI will not actually replace radiologists, but they'll enable them to see more and more patients. Maybe they can use this model to screen mammograms which are done at a peripheral center, so that the value addition across the chain takes place. So that is how AI is augmenting healthcare. Now, enough of all these. I think we all are more or less aware of all these models which are being used in radiology. So that's the first use case we all think of when we think about AI. Let us move on to new and innovative things. So what can happen? So medical students here, what can happen with AI if you want to study anatomy? So gone are the days when you go to the dissection room with actual cadavers and the stink of formalin, tearing up your eyes. There could be digital dissection tables, right? These have multiple layers of tissues. There can be customized modules which can be prepared, right? This not only helps you in learning, but it can also be used as a task. So you're given a tutorial in an exam to identify a particular set of a muscle, demonstrate a particular structure. You can see how easily you can remove, add, or subtract a particular image. So this is not just about the learning process. It can be also used for creating a test in the particular exam. I think when this happens, what we will miss though is the fun that we have in the first few days when we go to the dissection room and at least 2 or 3 of our colleagues fall down with a big thump, right? And that is what happens with each and every batch. My sense is that when they create such dissecting tables, they'll keep a sprayer of formalin just to create that sense of reality when we go into these digital dissection rooms. So yes, so that will create a virtual learning experience, right, without formalin. You can add it as an add-on if you want. Recently, the Nobel Prize in biochemistry or chemistry in the year 2024 was awarded one half to David Baker and the other half jointly to Demis Hassabis and John Jumper. Do you know for what? For developing AI-based models. What did they do? They used protein design and AI-powered productions. So look at them. They created softwares, AI-based softwares, and they were awarded the Nobel Prize for it. So David Baker created the Rosetta software, which creates new proteins with customized functions. Just imagine you have a software now where you can design an entirely new protein. You want to use it for a specific function. That can be done with this particular software. Demis Hassabis and John Jumper work with Google DeepMind. They created an AlphaFold 2 AI model. It predicts the 3D protein structures from amino acid sequences. Let me give you a quick example of how this would work. I'm going to use so it can be used in drug discovery, enzyme engineering, customized proteins. Let us come to a real life example, right? The past of COVID, right, is not very far away, right? We wanted to create an antibody which would attach to the spike glycoprotein of COVID. Now we know the structure of spike glycoprotein. What we do is we simply feed it to our AI model, and that because the target structure we already know, the AI model on its own will generate the specific antibody which is going to go and get attached or get latched to that particular spike glycoprotein. And that is how this will tremendously accelerate the process of drug discovery, right? Specific enzyme generation. So that is how in the field of pharmacology and drug discovery and development, this is going to take the process up at least by 3 to 5 years, right? So this is going to accelerate the process to that extent. Yes, now this is very, very interesting. See how fascinating work is being going on. So a known case of rectal cancer undergoing chemotherapy, right, is being prescribed ondansetron, right, to tackle with chemotherapy-induced nausea and vomiting. Now in the UC Health, that is University of Colorado, what they have done is they have developed a center of Colorado Center for Personalized Medicine, where what they have done is that we have an automated electronic health system, right, where PAC system, where all the patient information is being stored. What they have done there is that they have used or mapped the patient's pharmacogenetic information, and they have back integrated it into the electronic health record. So what happens is that this patient's pharmacogenetics data is already there in the system. So as soon as a physician adds a prescription of ondansetron for this patient, what the system does is it automatically generates an alert saying that this patient is a CYP2D6 ultra rapid metabolizer, which means that he is going to metabolize this drug of ondansetron so fast that it is not going to be effective in that particular patient at all. So there's just a pop-up window that comes up, and the window also then suggests an alternative drug, which is then automatically prescribed, and the patient has no toxicity at all. See how fascinating this is, right? What they have done is they have created a good electronic health record system, and they have integrated the pharmacogenetic information into it, and this all happens on its own in an automated manner in the background without any human intervention. So see how fascinating this work is going on all over the world. So impact is personalized medicine. The standard of care should not be standardized care. It must be personalized care. This is the new stream of precision medicine which is coming along these days. This is made possible just by these AI algorithms. Ophthalmology, yes, known diabetic comes for eye checkup at a peripheral center, undergoes fundoscopy. There is no retinal expert who is available there at the clinic. So what they do, they use a software of IDX. They use a fundus camera, get some good images of the fundus, right, and they upload it into the system. What the system does is that it saves the image, selects the patient, processes the images, and then based on the results, based on the processing, it gives us a score, whether this is there are any signs of diabetic retinopathy. Is it negative? Is it vision threatening? Is it severe one, or does the patient actually need immediate referral? So that is how AI is going to improve the accessibility to healthcare in the long, far away rural areas, peripheral areas where a specialist might not be available. AI will be doing that job for you. Of course, when you pick up a particular finding, you then know that this particular patient is going to need a referral to a higher center for further management of this particular condition. But this is something, so improved healthcare accessibility is what can be achieved by these models. So coming to medicine, now this is not even a model which needs to be used in a hospital. This is a model that we have been carrying along with us every day. And what is that? A patient is feeling sleepy and tired in the day, and he is wearing a device that many of us wear. And what is that? It is an Apple Watch. And this device that you are wearing on your wrist is in itself a proven AI model. What is it doing? It has a sleep tracking module in it. Go to your Apple Watch and get a sleep report generated. And this report analyzes the sleep time data for this particular man, and it tells that man, oh, you're not sleeping well. You're waking up at least 4 to 5 times every night. Why is that so? You need to see a doctor. Is it because of respiratory issues? Is it because of cardiac issues? Is it a sleep apnea? What is happening? So what AI is doing for you is that it is doing a very time efficient data analysis. You go to a physician and say, oh, I'm feeling very tired, right? The physician will prescribe you some multivitamins, because in busy clinical practice, we don't have the time to go through the sleep records for each and every patient. So simple prompt on your Apple Watch, right? Because of this pattern recognition, right, is going to create that prompt. You can go and see a physician with that particular, prompt, and that is where you can do targeted intervention. So see how fascinating this is. Yes, another important application is this WhatsApp consultation. I'm sure any one of us who practices as a clinician is sort of getting fed up of these innumerable WhatsApp queries. It started during COVID days, and we thought it was such a great way to communicate with patients. Now COVID is long gone, but the demon of WhatsApp consultation still remains. You're back home tired at 9:30 p.m. after a long and heavy OPD, and you have 12 messages on WhatsApp from different patients, asking you what to do. So here, what various universities have devised is a patient interaction WhatsApp integrated chatbot, where the patient messages, the doctor, the response is generated by the model, and you have two options: to edit it or to send it directly. So if you agree with that particular response, you send it directly. If you don't agree with it, it has created a template for you. You can make your own changes, and then you can send it to the patient. So be it basic queries, be it about the lab results, be it about follow-up reminders, all these things. So see, there can be a lot of fun which is going on in these automated interactions. Let me tell you a fun fact. When this was implemented at a prominent university in the US, you know what the response of many patients was to this model? They said that this model was responding in a manner which was too polite, and it did not actually seem like their doctor is the actual person writing these. So the instruction that they had given to this model was to be polite and precise. Based on this feedback, they removed one half of the prompt, and they asked the model only to be precise and not polite. And now the patients are really, kind of feeling they are interacting with their own doctor. So that is how the fun is going on with these models as well. And this is what I started my talk with today. Sepsis, which is a big problem that we are facing. So patient was operated, had a fever spike, tachycardia. Are there sepsis prediction models which are available? Yes. EPIC is the largest electronic health record system which is currently being used in the US. And what they did was, they created a sepsis prediction models based on basic vital parameters and integrated it into the electronic health record system. So if you are sitting in this conference room right now and one of your patients is admitted in the ICU and it gets a sepsis score of more than 6 in this model, you will get a prompt immediately on your cell phone saying that, oh, this is a patient who will likely go into sepsis very soon. And that is how you can act on it. So when this model was actually tested, right, they found that an alert was sent to the primary physician about potential sepsis. That helped in early recognition. So early recognition of potential sepsis about 6 hours in advance. That led to early interventions about earlier than 4 hours as compared to conventional in the absence of this model. And see, look at the impact. The impact was 44% mortality reduction. That's a huge impact that we are making for human lives, right, on human lives, and that is something that we need to really embrace. Now, till this point in time, I'll be honest with you, I have shared only one half of the picture with you. This is so fascinating. Look at the 44% mortality reduction, but this is just half of the story, because when there were extensive studies which were conducted, they found that this model is not very, very easy to implement. There are challenges. And what are those challenges? So this is one model where I'm going to discuss the not so good things or the challenges that come along with these AI models. So there was a racial and ethnicity bias in the primary data. So if we as Indians, we adopt this same model to be implemented in our country, it has been fed with the data which was done on the American population. It was not done on the Asian population or the Indian population, and so the vital parameters or triggers may be different. It may not apply to our patients what applied to their patients in their institutes. So that's a problem there. It is non-transparent. It is black box. We don't know how it gets to that score because it is proprietary, right? It is under the company called as Epic, and they have created it. We don't have access to that, and therefore we don't know what really goes along. What if the company has a commercial agreement with a pharmacological company, right, to sell these antibiotics and they are using it unethically? We don't know that because it's proprietary. The software is not tested. It has a low predictivity, positive predictivity value of 12% and a high false positive rate. So it was very difficult for me to make sense of this. So what I did was, I'll be honest with you, I took these 2 lines and I fed it into ChatGPT. And I asked ChatGPT, tell me, for each positive case, true positive case of sepsis, how many false positives is this model going to give me? You know what the model said? For each 1 true positive sepsis case, there will be at least 7 to 8 false positives. Just imagine this, you're a busy clinician, you get a sepsis alert on your phone. This is the first alert that you've got because you installed the model just now. You're so happy about it. You go to the bedside, you evaluate the patient. Oh, these are the parameters, and you think, oh, this is not really sepsis. I don't think this is sepsis. You ignore that, alert. You get a second alert. You go to the second patient. You go to the bedside, evaluate it, and you say, oh, this is not really a true alert. This is false. By the time you get to your 5th bedside patient, bedside care, you realize, oh, this model is not really working for me, right? Because all 5 that you have evaluated until now have not turned out to be true sepsis, right? It is only when you do it for 7 to 8 times is when you hit a true positive case, and that is where you can achieve that mortality reduction. So the problem with this model was alert fatigue. So many alerts throughout the day, and very few of them turning out to be true positive. So that's a problem there. Workflow disruptions. Each time you get an alert, you delegate somebody to go and look at that patient. It is not turning out to be very well. Antibiotic overuse, excessive testing is another side, flip side of this particular model. So you know what they did to overcome this? They tried to overcome this problem of alert fatigue. What they did was, they created a team of consultants, intensivists, who is not working in the hospital, who is working at a distant control center. All they are doing is, they are just looking at the alerts. They will screen these 8 alerts, go through them, try and pick up the true positives, and only that picked up, shortlisted alert will be sent to the primary physician. So that the primary physician ends up getting relatively lesser number of alerts with a more, with a higher, positive predictive value and a lower false positivity rate. But then, to develop this separate clinical monitoring unit, they had to spend a lot of money, resources, personnel. So there is a resource cost that also comes with it. Would it be practical for us in our healthcare setup to spend these kind of resources, creating an entirely separate unit just for the analysis of this particular data? Well, there's nothing right and wrong here. That is something for us to analyze and decide what needs to be done. So the point of this slide is that AI will help us as an augmentative tool in getting better. But is it as straightforward as it looks like? The answer is no. There are many challenges to it. And we need to address these challenges as we go about it, implementing it one by one. There are ways to get around it. It can be done, but we have to go through that rigorous process. That is what this slide is trying to tell you. So AI is actually a big boon for us, but also comes with its own set of bane. So we have ChatGPT, we have Cure AI, Epic, Lunit, iCAD, Viz AI. All these models are going to make our life better, make our life easier as clinicians. But when we use these, when we decide to use these models, we also have to be careful about patient privacy, ethics, consent issues, accountability, accessibility. Are we introducing any bias or fairness, or unfairness into the system? We have to take care of that. So these are the challenges that we as doctors are going to face when we decide to adopt these models. So what do we need then? What do we need to do? What do we need to tackle these issues? We need chai. Everybody needs chai. We love chai. Well, chai in this context is a committee on health in AI. So every institute, particularly an academic institute like this one, I am too small and too insignificant a person to suggest what needs to be done. I am not trying to do that. I am just trying to put forth my ideas. Each institute needs a committee. This is like an IRB, an institutional regulatory board. This would be a committee that decides everything about AI implementation in that institute. It would need to be a combination of experienced as well as young doctors. Young doctors sitting here in this room are going to be the pioneers of all the AI models that we use. I have been privileged to be a part of app which uses AI extensively, and that is Marrow. Marrow is not just a teaching platform, but it has also helped transform students' lives in clinical practice. Do you know how Marrow was created? Marrow was created by an intelligent guy who's not an engineer, an MD medicine guy by the name of Dr. Deepu Sebin. He was a MD medicine resident at Stanley Medical College in Chennai. While he was doing his MD medicine residency, he came up with an idea of a electronic, digital learning platform, and that is how Marrow got actually created, and it has come ahead leaps and bounds since that time. So many of the young students sitting in this auditorium here are going to come up with disruptive ideas, disruptive in the good sense, right? But the ethos of, ethos of the Bay Area or California or the IT industry is to disrupt things, turn them up and down. We can't afford to do that because we are in healthcare and there are lives at stake. That is where the senior consultants would bring in their experience. They will sort of put up some guardrails. The committee reviews and approves all the AI related proposals in that particular institutes. The experienced doctors come in with their guardrails, safety checks, ethics for implementation of AI. So we can do an informed and cautious adoption of these particular tools going ahead. So we need a combination of both. And that is, I think, a safe way to adopt AI into our day-to-day practice. Now I come to the million-dollar question that we want to ask. We want to know what is the correct perspective that we should have about AI. Will AI replace doctors? I don't know, to be honest. All I can tell you is what I think about it right now. Time will tell whether I am right or wrong going ahead. I feel that AI may not directly replace doctors, but one thing is for sure, that doctors using AI will definitely replace doctors who are not using AI. That is for sure, because those who use AI in our day-to-day practice will be more efficient, will be better at that work, will be able to cater to more patients, save more lives, and that is how we will perform better than our peers who will choose not to adapt this. Okay, will patients agree to be treated by AI bots rather than doctors? I think this is not so difficult to answer. I think the answer is you won't want to be operated upon by a robot, right, who is an autonomous robot, right, because things can go wrong. You don't want to entrust your life with a device like this as of in the near foreseeable future. Well, an AI can crack exams, an AI can make a precise diagnosis, but it can definitely not hold the hand of a patient, look into the eye of the patient and reassure him. An AI may not be able to understand the sarcasm that a patient is using while narrating his complaints. Medicine is a fusion of art and science. AI may master the science, but the art still remains human. Now, if I imagine a future going ahead where there is a partnership between a doctor and an AI, I feel that AI will bring in speed, it will bring in precision, it will bring in efficiency, it will bring in more accessibility. But it is the doctor involved who will bring in more empathy, who will bring in wisdom that comes from his experience, and most importantly, the doctor will bring in his human touch as far as saving lives and treating patients is concerned. This is an exciting time to be practicing as a doctor in medicine, isn't it? Don't you agree? Thank you very much for your patient audience. It was great interacting with you here. If there are any questions, any interactions, any experiences that you want to share, I would be more than happy to address them. Thank you very much.